introduce Dr. Saloni Arora. She's MBBS MD in obstetrics and gynecology certified. She has done her fellowship in. She is a very, very academically oriented. Are you able to hear me now?
Yes, ma'am. Voice is better now.
1 minute. Let me just put this on. Let me see. I'm having connectivity issues. Better? Hello.
Yes, ma'am. Go ahead. Please go ahead.
Is this better?
Yes, ma'am.
Yeah. So it indeed gives me great pleasure to introduce Dr. Saloni, who's a dear friend and colleague. She is a fetal medicine specialist and she's done her fellowship from Apollo Center for Fetal Medicine. She's a very, very academically oriented person and has numerous publications in various prestigious international journals, including the American Journal and BJOG. She is currently leading the fetal medicine department at BLK Max Super Specialty Hospital. So over to you, Saloni.
Thank you so much, ma'am. Thank you, Chanchal ma'am, for such nice words. Thank you, Dr. Ankit, Dr. Ankur. Thank you, IIP Central Delhi branch for giving me this platform where I can discuss this important aspect of fetal medicine, that is fetal interventions. So I'll start share my screen. Okay, Dr. Swati, is my screen visible?
Yes, Dr. Saloni.
Okay. So, identification of congenital birth defects and the fetal malformations have greatly improved over the last few decades. And because we could identify more and more congenital malformations now in utero, the number of innovative therapies have also amplified. Before going into what all fetal interventions we can offer these days or what are likely to be developed in the near future, just a quick word about that. The first successful fetal intervention procedure which was done was intrauterine blood transfusion. It was done in 1963 and it was started by a intraperitoneal route, and now we are doing it by the intravascular route. And over the last 3 decades, there is a progressive development of the prenatal intervention and the surgeries. And today, the prenatal surgeries and interventions, being it therapeutic or diagnostic, have become an integral part of high-risk pregnancies management. Before offering anyone the fetal intervention, either diagnostic or either therapeutic, there are few ethical considerations that we have to keep in mind, that we should be aware that when we have to intervene, whether it is necessary to intervene and how to intervene, and the decision to intervene must pass the following important criteria: that the invasive therapy, whenever we are doing, have a high probability of being life-saving or preventing serious irreversible mental or physical disformity to the fetus or the child to be born. Second, the invasive therapy which we are offering should possess low mortality risk, and it should have low and manageable risk of serious disease to the fetus. Most important is that the maternal mortality and morbidity while offering the fetal intervention, whether it is a diagnostic or therapeutic, should be very low and manageable. Whenever we do fetal intervention, the autonomy of the pregnant woman is very important, and the clear decisions that why we are doing it, what the results they are expected, and how we are going to proceed it further should be discussed with the women, with the pregnant woman and the family in much more detail. So we categorically divide fetal intervention into 3 types: the fetal interventions which are guided by the ultrasound, second are the fetoscopic procedures, and the thirds are the open fetal surgery. Let's start with the fetal interventions which are guided by the ultrasound. Among these, there are few which we are commonly performing in day-to-day practices, and then there are few which are less commonly performed. Among commonly performed are amniocentesis, chorionic villus sampling, multifetal pregnancy reduction, and intrauterine transfusion. Among less commonly performed are few shunting like vesicoamniotic shunt or thoracoamniotic shunt. Then there is a selective feticide in complicated monochorionic diamniotic twin pregnancies, or there could be fetal cardiac interventions. And lastly, there is a scar ectopic or cervical ectopic managements. I will be quickly touching on each of these procedures, just few indications and a very brief brief that how they are done. Let's start with the amniocentesis. It is the most common prenatal diagnostic procedure that we offer in a fetal medicine department. The common indications of offering amniocentesis are mainly the diagnostic one. Whenever the pregnant woman is screened positive for the common aneuploidies, that is the trisomy 21 or 18 on double marker, quadruple or cell-free fetal DNA, then if the fetus has some structural anomaly, or there is a risk of inherited genetic disease like a thalassemia, both the parents are thalassemic carriers, or there is a previous child which is affected with the genetic mutation or the genetic condition where there are high chances that it can reoccur, or we are suspecting some fetal infection like mother is torch positive for IgM and negative for IgG, or there is severe early onset FGR, that is a fetal growth restriction less than 24 weeks, or sometimes the parents just want to know whether the baby is going to be genetically normal or not, then also the amniocentesis can be offered. Therapeutic indications in cases of amniocentesis are less, but still it can be offered in the cases of when we have excessive polyhydramnios to relieve maternal discomfort or to prevent preterm birth, or also in the cases of twin-twin transfusion syndrome. So it is a comparatively quite a simple procedure done in the OPD basis, hardly take 5 or 10 minutes and the procedure is completed. No local anesthesia is needed. The 22 gauge spinal needle is used. We usually select the amniotic fluid pocket, that is placental flea is selected, and in case we are using transplacental approach, the placental cord insertion is avoided. The risk of miscarriage that we quote with amniocentesis is 1 in 500. So it is comparatively a simple procedure. Coming to the second procedure, that is a chorionic villus sampling. The indications of offering chorionic villus sampling is more or less same like the amniocentesis. The chorionic villus sampling definitely have few advantages over amniocentesis, that we could diagnose a genetic disorder early like trisomy 21 or thalassemia, so that the patient can have an option of early termination of pregnancy, but it is more skillful and slightly challenging than amniocentesis. It is done between 11 to 14 weeks of pregnancies. Earlier, it started with a transvaginal approach. Important thing to be noted here is that now the transvaginal CVS are obsolete because there are higher chances of leaking and then the fetal malformation. So the CVS nowadays are always done by a transabdominal approach, where we, by inserting the 18 gauge needle inside the maternal abdomen and inside the placenta under proper ultrasound guidance, the small placental tissue or the villi are taken and they are sent for the genetic testing. The risk of miscarriage that is quoted with the amniocentesis and the CVS is similar, that is 1 in 500. Most of the people says that CVS is more, the CVS has more complication rate as compared to amniocentesis, but done by experienced operator, amniocentesis and CVS have similar miscarriage rate, similar risk of infection, similar risk of culture failure. It is just that if we are identifying any problem in the fetus in the early scan like NT scan, then we should be offering diagnostic testing at that time only, and we should not be deferring it after 15 weeks. The third common procedure that we do ultrasound guided in the fetal medicine department is a multi-fetal pregnancy reduction. Over last few years, the incidence of multi-fetal pregnancies have gone up because of the use of ART. And there are n number of studies which shows that if multi-fetal pregnancies like triplet or quadruplet, if they are reduced to twins or singleton, the chances of maternal as well as fetal complications are quite less as compared to if they are continuing as a triplet pregnancies. Of course, the risk of maternal complication in terms of PIH and GDM are less, and in terms of fetuses, in terms of babies, the risk of miscarriage, fetal growth restriction, prematurity, and the CP is definitely less. The most important thing is that the financial burden to the family is quite less if the pregnancy is allowed to carry it as a triplet as compared to if it is reduced to a twin pregnancy. So the multi-fetal pregnancy reduction, if it is done between 7 to 8 weeks, it is done by a transvaginal approach that is known as embryo reduction. And if it is done after 11 weeks, it is done by a transabdominal approach and it is known as a fetal reduction. We prefer fetal reduction. There are few advantages of offering fetal reduction as compared to doing an embryo reduction. First, it is safer and a better approach. And till 11 weeks, there are quite high chances that there is a spontaneous divine of one fetus in triplet or quadruplet pregnancy. So we might not to intervene. And whenever we are doing reduction, we have to be sure that the fetus that we are reducing is at least for the common structural and the common chromosomal problems is fine. So we first tend to do a nuchal scan, and that is if normal, then we would like to proceed for a fetal reduction. In cases of a dichorionic pregnancies, the fetal reduction is done by a injection of potassium chloride in the intracardiac, and in monochorionic, it is done by the interstitial laser. This is a small clip showing that how the needle is inserted inside one of the fetal heart, and the other is simultaneously visualized that it is breathing, it's beating properly. Third procedure that we commonly offer is the intrauterine blood transfusion. The common indications for offering intrauterine blood transfusion is a fetal anemia. The most common cause of fetal anemia we all are aware is Rh isoimmunization, that is Rh incompatibility. But luckily, because of the use of NTD injections and so much awareness, these cases are becoming less. But still, nevertheless, we still see a few of Rh isoimmunized pregnancy, because many a time the NTD dose that is given antenatally or post delivery sometimes does not compensate the increased amount of fetal-maternal hemorrhage that has happened at the time of a delivery. The other causes of fetal anemia are non-RHD isoimmunization, that is because of the atypical antibodies like NTE or NTK. The other causes of fetal anemia are some infections like parvovirus B19, where we tend to do intrauterine transfusion. Also in the cases of TAPS for donor twin, where we don't have a facility of laser coagulation, we can offer a fetal anemia to the donor twin. The other indication is when we have chorioangiomas where the baby is bleeding inside the placenta, then also we can do a transfusion, and also in the cases of fetal-maternal hemorrhage. It is the most successful fetal therapeutic procedures. The optimal candidates are the babies who have severe fetal anemia at 18 to 35 weeks. Indication is that when on the ultrasound, the MCA PSV is more than 1.5 mom, we do first chordocentesis. We take out 1 ml of fetal blood that is sent for the HB testing, and if it is less than 10, then the fetal blood transfusion is done. The most important thing that we have to keep in mind while doing blood transfusion or intrauterine blood transfusion is that the blood unit that we are preparing has to have a high hematocrit of 75 to 85, because we don't want to overload the baby that is already anemic. It's the same principle that applies to any pediatric or the adult individual who is severely anemic. Then it has to be a fresh donation. It has to be leukocyte depleted, infection screen. Usually we give O negative blood, but if we know the blood group of the baby, then ABO identical blood group can be given. So far we have discussed about the commonly performed fetal intervention which are guided by the ultrasound. Let us discuss few less commonly performed fetal interventions. First, I would like to start with the vesicoamniotic shunt. So the most common indication where we are offering vesicoamniotic shunting is a LUTO, that is a fetal lower urinary tract obstruction. And it is most commonly caused by the presence of posterior urethral valves. The other less commonly causes which can result in the LUTO are anterior urethral valves or urethral atresia, urethral stenosis, or obstructive uretrocele. LUTO, the babies or fetuses with having LUTO, if left untreated, they have very high perinatal mortality because of pulmonary hypoplasia and renal failure. However, before offering the vesicoamniotic shunting, the appropriate selection of candidates is very important. That is, it has to be isolated anomaly, that it has to be isolated lower urinary tract obstruction. There are no other severe cardiac or brain or other structural anomalies, and we have done proper genetic evaluation. Baby is not having chromosomal abnormalities or some deletion and duplication. Then we have to be sure that the renal function is preserved. And how can we check that? On the ultrasound, we look for the renal morphology, that the kidneys are not looking hyperechogenic. There are no renal cortical cyst, and there is the corticomedullary differentiation is still preserved. Or we can do repeated vesicocentesis, that is usually done thrice, where the fetal urine is aspirated from transabdominal route under ultrasound guidance, and it's tested for the urinary biochemistry. And if we are sure that the fetal kidney function is preserved, then we can offer a vesicoamniotic shunting to the parents. Just a few words that how it is done. So in cases of luto, usually we have fetuses where either it is a severe oligo or anhydramnios. So in such cases, before going to the shunting, we have to do amnio infusion, which is followed by an insertion of double pigtail catheter under ultrasound guidance, and then the distal end of the catheter is deployed inside the bladder, and the catheter is taken out from the urinary bladder, and then the proximal end is deployed in the amniotic sac. There are two types of shunts that we can use. Either it is a Harrison shunt or rocket shunt. The rocket shunt has found to be a better, that because of this shunting, the important complication that can happen is dislodgement. So rocket shunt has found to have a increased likelihood that it remain in place as compared to the Harrison shunt. There are many studies which have evaluated the renal function of the babies who have undergone fetal intervention like vesicoamniotic shunting in the cases of luto. And then there was a recent systemic review and meta-analysis which have shown that definitely the perinatal survival increases whenever we are doing vesicoamniotic shunting in the cases of luto. However, 1 to 2 year survival and the long-term renal function are still uncertain in these cases. The alternative antenatal treatment option which is under research these days is the fetal cystoscopy, where the mechanical or the laser fulguration of the posterior urethral valves is done. But as I said, it is still under research, and there are current limitations of the equipment, and the expertise is definitely less, and there are the case report of fetal fistula formation. So this is not something that we are routinely offering to our patients. The second shunt that we do is a thoracoamniotic shunt. The indication is the fetal pleural effusion, that is the primary cause, or there can be some large fluid-filled space occupying the chest lesion like congenital cystic adenoid malformation, that is a macrocystic type. The prerequisites of offering thoracoamniotic shunting is same as offering a vesicoamniotic shunting, that it has to be isolated, and normally there should not be other structural malformations, and the baby should be evaluated genetically. There should not be infections, and the fetal heart function and the morphology is fine. The criteria in which we offer thoracoamniotic shunting is that is not in all mild pleural effusion we are doing shunting. So whenever we have moderate to massive pleural effusion which are causing cardiac dysfunction, which lead to hydrops or polyhydramnios, which can result in preterm labor or shortened cervix, we tend to offer thoracoamniotic shunting. Or there is an isolated effusion which is occupying more than 50% of the chest space, and or there is a rapid increase in the effusion size. Same, the principle of doing the thoracoamniotic shunt is same as the vesicoamniotic shunting. Similar shunts are used, similar catheters are used. However, usually before offering shunting, we tend to do thoracocentesis because we want to evaluate sometimes just with a single tap the pleural effusion that we have aspirated all this pleural effusion, pleural fluid, and there is no reaccumulation of the fluid, so it solves the purposes. But in case there is a reaccumulation of the fusion after thoracocentesis, we tend to do thoracoamniotic shunting. Also, thoracocentesis before offering thoracoamniotic shunting is done because we want to check whether there is a re-expansion of the lungs, and also we want to evaluate the pleural fluid for lymphocytes to look for the cause of the pleural effusion. Most common cause is chylothorax in fetal life, the cause of pleural effusion. So this was so far about the shunting. That is the less commonly offered procedure that we do. The third procedure, ultrasound guided, that we offer in some cases is the selective feticide. It is different from the multifetal pregnancy reduction. So multifetal pregnancy reduction is done when we have a triplet or quadruplet or twins, where parents want to continue as a singleton or twin pregnancy. However, the selective feticide is something which is done in cases of monochorionic diamniotic twins, or sometimes in a dichorionic twin, when the one baby is either suffering from a severe structural malformation, or the selective termination of one fetus is an option to protect the healthy co-twin. Like in monochorionic diamniotic twin pregnancies, because of the presence of anastomosis vessels in the placenta among both the twins, there are chances of having few complications which are specific to monochorionic placenta, that is TTTS, twin anemia, transfusion syndrome. Then there could be a selective fetal growth restriction. There are chances of having TRAP, that is twin reversal arterial perfusion, or there are chances of having TAPS, that is twin anemia polycythemia sequences. So in cases where these complications set up quite early in pregnancy, like suppose at 18 weeks, 20 weeks, or we don't have enough expertise to offer lasers, or there are cases where monochorionic twins, one baby is having a severe lethal malformation. So in such cases, we tend to offer a selective termination of one fetus to protect the healthy co-twin. Unlike dichorionic twins, we cannot just do a intrafetal like thoracic or cardiac injection of KCL for for doing selective feticide in complicated monochorionic twin, because there are presence of vascular connections, and there is a risk that this KCL might pass to the other baby, and it could result in bradycardia or demise of the other twin as well. As so the options by which we can offer selective feticide in monochorionic twin pregnancies is by either doing interstitial laser, or by using radio frequency ablation, or by doing bipolar cord coagulation. So which procedure has to be done, when it has to be done, it depends upon the gestation, at which gestation we are doing, what is the indication, and the most important is the operator expertise in that. Like among all these three, interstitial laser and RFA are comparatively easier and less expertise involved as compared to BCC. However, if we have to do a selective feticide at later gestation, like 23, 24 weeks, we tend to offer bipolar cord coagulation as compared to if we are offering it at earlier gestation. So the other fetal interventions that we are offering these days is the fetal cardiac interventions. Fetal cardiac interventions, the most common one which we are offering is the aortic balloon valvuloplasty, which is done in the cases of the critical aortic stenosis. So the main purpose of doing aortic balloon valvuloplasty is that we want to prevent the progressive left ventricular dysfunction and to prevent the postnatal single ventricle physiology. And it has seen that with successful balloon valvuloplasty, the biventricular physiology can be achieved in up to 40% of the live-born neonates. The other fetal cardiac intervention is that we can offer is pulmonary valvuloplasty in the cases of pulmonary stenosis, or in the cases where we have restrictive foramen ovale in HLHS, hypoplastic left heart syndrome, we can do a creation of the arterial septostomy. So just a very few words that how it is done. So it is done in under a local anesthesia. Again, the mother is put in a supine position. The ultrasound guided under ultrasound guidance, 17 to 18 gauge needle is inserted and guided into the fetal heart. Obviously, before offering this procedure, the fetal anesthesia that we usually use of vecuronium in the doses of 0.2 milligram per kg is given. The needle is then aligned into the left ventricular outflow tract, and the trocar is removed, and the guide wire, which has a preloaded measured balloon, is advanced to the valve. And once we are sure that the balloon is placed across the left ventricular outflow tract, the balloon is inflated and then deflated, and then the whole system is removed with the needle. However, though not many centers are, at least in India, are currently offering fetal cardiac intervention, and also the data which is coming up all across the world shows that it still involves a significant morbidity and mortality risk to the fetus, and we are still not sure about the long-term risk and benefits that the baby will have after offering in utero aortic or pulmonary balloon valvuloplasty. So we have covered the fetal interventions which are guided by the ultrasound. Let's move on the fetoscopic procedure that we can do. So among fetoscopic procedures that we can do in the in terms of fetal medicine branches. The first is laser photocoagulation of the communicating placental anastomosis. Second is a feto, that is fetoscopic endoluminal tracheal occlusion, and there are few other fetoscopic procedures. Let's discuss shortly all of these procedures. So first is the laser photocoagulation of the communicating placental anastomosis. So it is offered in the cases of twin transfusion syndrome, which complicates around 10 to 15% of monochorionic twin pregnancies. It is done between 16 to 25 weeks of gestation. We all are aware that TTTS babies, if left untreated, they have very high fetal mortality. And why these fetuses in the monochorionic pregnancies have developed TTTS is because they have unbalanced vascular connection in the placenta, and there is a unidirectional flow from one baby to the another baby, which results in hypovolemia in the one twin, or which is labeled as a donor twin, and hypervolemia in the other baby, which is labeled as a recipient twin, and ultimately it can lead to the cardiovascular imbalance. So we have to intervene. So what we do is that we anastomose these vascular connections which is present inside the placenta. So just quickly, that TTTS is divided into 4 stages, into 5 stages according to the Quintro staging system, and the indication of offering laser therapy starts from stage 2 onwards. However, in stage 1 also, when we think that there is a progressive polyhydramnios which can result in a preterm contraction, we tend to offer a laser photocoagulation, and it is usually offered between 17 to 26 weeks. I just don't want to go into the detail of all these procedures. Just quickly, before any fetoscopic procedure, being it is a laser photocoagulation or a feto, the mother is given tocolytic, the prophylactic antibiotics are given. It is usually done under sedation or local anesthesia. First, the 18-gauge needle is inserted under ultrasound guidance into the placental or cord-free pocket, and then the trocar, which is the plastic cannula, or the trocar, which usually has a size of 5 to 16 French, is inserted. So in a laser photocoagulation, we enter our fetoscope and we identify the equator where we can see these vascular anastomosis, and then using the laser fiber, these vascular anastomosis are coagulated. Second procedure that we offer by fetoscopy is the feto, that is a fetoscopic endoluminal tracheal occlusion. The most common indication of offering it is a CDH, that is a congenital diaphragmatic hernia. The main aim or the basic that why we do feto in the cases of CDH is that we want to occlude the trachea so that there is a escape of pulmonary fluid from the lungs, and we could have the pulmonary hypoplasia, because in the cases of CDH, that is a congenital diaphragmatic hernia, it is not the pathology which results in a fetal demise or early neonatal demise. It is the pulmonary hypoplasia, because the abdominal structures are present inside the thorax, and which does not allow lungs to expand. So the baby is having severe pulmonary hypoplasia, which results in pulmonary hypertension and ultimately early neonatal demise. So so feto was developed where we want to occlude the trachea, and we want to increase the airway pressure so that we could stimulate this pulmonary proliferation and alveolar airspace, and we could promote pulmonary vascular development before it sets in. Very quickly, the few steps that how it is done, that again, before offering feto, we have to be very, very sure that it is the isolated anomaly. There are no other structural malformation. The baby has been evaluated genetically. It is usually offered between 26 to 29 weeks. Few centers have studied early feto also, but the potential benefit is still to be evaluated. It is the once we have inserted the balloon, it has to be removed at 34 weeks. And the patients are instructed that they have to stay nearby to the hospital where the facility of the exit procedure or emergency balloon removal is available in case she goes into labor. So prior to starting the procedure, we have to be in utero, the baby is positioned in such a, we have to wait till the baby is positioned with the face up. Then the fetal anesthesia is given, and with the complete facial profile in the sagittal plane, the trachea is assessed and the balloon is placed. And the balloon retrieval procedure is also similar as compared to the balloon placement procedure. Based on the prenatal CDH registry and the total trial, it has been seen that in the cases of severe CDH, left-sided as well as right-sided CDH, offering antenatal feto is definitely has advantages. Like it increases the survival from 24 to 50% in the cases of left-sided CDH, and right-sided from 0 to 35%. However, in the cases of moderate CDH, it is still not clear whether we should be offering feto or not. In India, I don't think that very few centers, maybe in the south, 1 or 2 are actually doing feto, because the balloon that is used to put inside the trachea, it is still patent in the US and the UK, and we don't have that balloon. We in the south, I think Chanchal ma'am, Suresh sir is trying to develop its own balloon, so that, if I am not wrong.
I'm
Hello.
Any procedure that's been done so far. I don't think any procedure has been done so far.
Because we don't have balloon, because I heard that they are
You can't hear me.
Okay, so I'll move
Yeah, so
forward.
far, I don't think any procedure has been done.
Yeah, so far we have not done any. So other fetoscopic procedures that we can offer is the release of the amniotic bands. The amniotic band sometimes can, if identified during antenatal scan, can result in in limbs or some limbs amputation or fingers amputation. So if we are identifying that, we can release these amniotic bands by fetoscopic laser coagulation. Or in the cases of vasa previa, we can do laser photocoagulation of these blood vessels. And again, in the cases of chorioangioma, because in chorioangioma, if we have large placental chorioangiomas, because of the presence of arteriovenous shunt, the babies can have high output cardiac failure. So in such cases, we can intervene and we can do laser coagulation of the blood vessels that are present inside the chorioangioma. So let's move on to the last part of the talk, that is a open fetal surgery. So open fetal surgery, what does it involve? It involves that we do surgery on the fetus by doing hysterotomy. That is, we open the mother abdomen, we take out the uterus, we give incision over the uterus, and then the baby is taken out while it is still on the placental circulation, and the part which has to be operated is exposed, and then the desired surgery is performed, and then the baby is put inside the uterus. The amniotic fluid is replaced with the warm saline, and then the uterine incision is closed in the single and the double layer. Few conditions where we are offering open fetal surgery is the open spina bifida, that is in the cases of myelomeningocele. There was a trial which the MOM study which shows that there is a decrease in the rate of postnatal shunt if we do in utero repair of the spina bifida from 80% to 40%, and there is an improvement of the mental and motor function, but still these babies suffers from the urinary incontinence, and the bladder dysfunction is and the bowel dysfunction is also there. And in India, currently, we are still not offering open surgeries for spina bifida. Other condition in which we can offer open fetal surgeries or are offered in other part of the world is the congenital cystic adenoid malformation. In cases where we have large lesion, we can just do shunting. However, in the cases where we have large microcystic lesions, which can leads to mediastinal shift or cardiac overload, or the baby can develop hydrops, we tend to excise these lesions in utero only. The other indication where the open fetal surgery has been done or is offering is the sacrococcygeal teratoma, and it is usually done in less than 28 weeks. In such cases, the teratoma part which is exposed outside only is removed. However, the one which is inside the baby would definitely need surgery postnatally for that. So it is the brief. I have already discussed that how it is done. Before offering open fetal surgery, we have to discuss in detail about the major maternal and fetal complications that can happen. Among maternal complications, there are very high chances of preterm labor, premature rupture of the membrane, or the chorioamniotic separation. Apart from that, there is a chances of dehiscence of the uterine scar. And very importantly, there are chances, there is a potential risk of developing placenta accreta in the subsequent pregnancies. And also the mother would need delivery during this pregnancy as well as in the subsequent pregnancy by a cesarean section only. And the fetal complications are also there when we are doing open fetal surgery. That is, the baby can have fetal bradycardia. There are chances of death during the position. And then, of course, the other complications of the prematurity are there. In terms of what the future looks for fetal surgery is that these repair of open spina bifida and other things where we are doing open fetal surgery, they are trying to do it with a fetoscopic procedure so that the maternal morbidities are comparatively less. Also, there are studies where they are evaluating the repair of the gastroschisis, where they do closure and the coverage of that defect once we are sure that it's isolated anomaly. So these are the conditions where we might be developing the fetoscopic procedures in the near future. So I think that's it. That's all that I have to discuss in terms of fetal interventions. Thank you. Thank you so much.
That
think,
was very.
No, thank you. I think Dr. Chanchal, you should take because I'm a neonatologist, so we expect you to comment first, and we'll discuss something.
Yeah. That was a very exhaustive talk. Saloni has tried to cover almost all the aspects of whatever is available. And we do have quite a few options, but we do not have many of the fetal therapeutic options as of now. So I think this branch is rapidly evolving. And as the parents get to know about it, they many times facilities develop because parents ask for those facilities to be developed. And I think fetal therapy is going to be one of those branches. So we are obliged to cater to the demands of our patients, and that's how it's progressing. Nice talk, Saloni. Very.
Thank you. Thank you, ma'am. Do we have any questions, Dr. Swati, or Dr. Ankur can give his?
Dr. Ankur, as we don't have any questions as of now. Dr. Saloni, I would like to ask about the vesicoamniotic shunting that you mentioned. So anything about the timing and how early or how late in the pregnancy can we do it? And how does it affect the pulmonary hypoplasia? Does it also affect the development of other complications?
So usually we pick up these conditions, like obviously if it is a severe luto, it can sets in the first trimester only. But usually at the time of a level 2 scan, when like 18 weeks or 19 weeks, we are picking up these anomalies, that is a lower urinary tract obstruction. So that is the gestation at which we usually tend to offer. If it is a late, like I have not seen any case of severe luto after 25 or 26 weeks. Usually they are picked up at the time of 18 to 20, at the time of a level 2 scan. So because there is a lower urinary tract obstruction, the kidneys, though initially they are producing the urine, they are functioning, but because it is not coming out, and it result in oligo and hydromnios, and because of that the lungs, there is not enough space for lungs to expand. That's result in the pulmonary hypoplasia, and that is the main reason that the baby has early fetal demise or the early neonatal demise. Yeah, definitely with time, because of the back pressure, the renal functions are also deteriorating, and that ultimately results in the renal failure or chronic renal disease. So whenever we tend to intervene, whether we are doing vesicoamniotic shunting or cystoscopy, we want to intervene before these irreversible damages that sets up in the fetal kidneys.
Thank you, Dr. Saloni. But I think currently this is being done only in select centers, and we need to, it's very important, as you already said, that it's important to select the patients carefully to optimize the outcomes.
I think I'm rejoined, Swati.
Yeah.
Yeah. Okay. Thank you, Saloni. So first of all, congratulations to TelePage's team. I think Swati, Ankit, and the IP Central team are working very hard to, give an important, relevant topic. And this topic is very relevant. Not only relevant, it's a very evolving topic. And we can see the two fetal specialists. And in future, I hope that you both would be doing the fetoscopy and the feto also. So I think there are few comments. One disclaimer is that I think I'm not a fetal intervention specialist, but they cannot work without neonatologists. So because the risk of prematurity in pulmonary hyperplasia are very high. So unless until you have a good team, you cannot give a good outcome. It is not only the interventions. Unless until you have a better outcome, you can't do interventions. So Saloni has talked about three topics like the USG, fetoscopy, and fetal surgery. I think the USG is being used for the amniocentesis. They are exclusively part of it, the fetal, diagnostic approach, and sometimes there's some interventions approach. The there are few things. Think there are three major trials. She has already talked. One is MOMS trial. MOMS trial was done, in the year 2011, and they definitely found that the outcome of the electrolytes were better in form of, decrease the rate of shunting and the motor outcome were better. The second, one of the landmark trial was the Pluto trial. However, in the Pluto trial, the lung part was better. That's why survival was better during the first 28 and 1 year of life. But the renal outcome were poor. So we have to look for whether we are ready for that or not. Because as far as I feel that the renal part is very bad. I think if you survive the baby and by 2 years, 3 years, they would require renal transplant. So we have to counsel the parent, properly. Third, the landmark trial was the FETO trial. I think they are one of the best trials as far as the type of study and the robustness of the study was it was a multicentric trial. And from this, so you certainly know that the outcome of severe CDS from left side CDS was better. Am I audible?
Your voice is breaking in between.
Okay. So I was traveling, that's why. So I think the outcome were certainly better. You showed that it increased from 24 to 50% of the severe diabetic hernia. But if you look closely, the study of the fetal outcome, the risk of premature delivery was very high. Risk of premature delivery was very high. In fact, before 34 weeks, the risk of premature delivery was in the range of 40%. That is almost 4 times high. So overall, the survival of that CDS improved. Hello.
Yes, Dr. Ankur.
We can hear you. We can hear you.
Okay. So overall survival has improved, but the risk of prematurity was very high. It was 4 times higher. So we have to decide very carefully. Okay, and the third part that overall we have to think that we should not do harm to any mothers and the fetus. And if I can get the better outcome, then we can consider for fetal. Sorry, I think.
I agree with Ankur there that our first role as clinicians is to first do no harm. That applies to both the fetus as well as the mother. So as you rightly pointed out, the Pluto trial, as of now, till now, we do not have any convincing before the pulmonary hyper, before they would want to do a vesicosynthesis, ensure that the fetal urine parameters do not show end-stage renal disease. And even when that is all normal and you've put in a shunt at the correct time, which is what was being done in the Pluto trial, 50% of babies still ended up having end-stage renal disease. So I think counseling is very important, because it's not just about prolonging the gestation, having a live baby at birth. I think it is equally, the quality of life is equally important. So that and we cannot, fetal medicine cannot exist without the neonatologist. So there is no question of you not being on the team. So
True.
yeah.
I'm sorry, I was traveling, so my voice was breaking. I think I have one question to both of you. I think you discussed about the TS and the thoracoamniotic shunt. It looks, feasible, and we can probably improve the outcome.
Yes.
There is
So
one issue.
thoracoamniotic shunt has excellent outcomes. See, we must understand the difference. The pathology is different.
Yeah, exactly.
So the pleural effusions, carefully selected primary effusions, if we in between we were not getting the shunt. So because of some change in government regulations, so the procedure of procuring the shunt was difficult. But the thoracoamniotic shunt has excellent outcomes, in contrast to the vesicoamniotic shunt.
Yeah.
So, but when I was going through the literature, what I could found that so the chances of dislodgement is very high. So, what you expect from neonatologist at the time of delivery, if it gets dislodged right in the chest, do we need to remove that shunt, or you just left it?
There are follow-up papers where even after 10 years of at 10 years of age, a dislodged shunt which migrates inside the lung has not done any harm to the child.
Okay.
So if it gets dislodged inside, it doesn't matter. If it gets dislodged outside, one can cite it again if more in utero time is left. At the time of birth, the neonatologist just needs to ensure that you clip it immediately after birth so that it doesn't become a conduit to create a pneumothorax.
Okay. Thank you. I thank you. It was excellent talks, Saloni. Thank you.
Thank you very much.
Thank you, Dr. Chanchal.
Thank you, Saloni. Thank you.
Thank you,
Dr.
Chanchal
Ankur.
ma'am. Thank you, Dr. Ankur. Thank you, Dr. Swati.
Yeah.
Bye.
Yeah. On behalf of BLK Center for Child Health and IP Central Delhi, I thank everyone for attending this webinar. Thank you, Dr. Saloni, for such a lucid presentation. Of course, fetal intervention is an upcoming field. Maybe in future, as we accumulate expertise, outcomes will be even better. Thank you, Dr. Ankur and Dr. Chanchal, for your valuable inputs. The recording of this meeting will soon be available on the blkpediatricpractice.com YouTube channel, and we'll also circulate this link. And next month, we'll have another webinar in this series. The details will be circulated. Thank you, everyone. Thank you.
Thank you. Thank you.
Bye-bye.